Good afternoon, good morning, good evening, depending on where you're joining us from. Welcome to this webinar called Innovation Exchange, Investing in COVID-19 Community Response. We are excited that you've been able to join us. In this webinar, you'll be able to hear some of the innovations that have been implemented under catalytic funding by some of the community-led organizations. But you'll also be able to hear some of the new innovations that are going to be implemented under a new acceleration innovation project. We'll take time to hear some of the community voices. So this is a moment for us to just learn some of the key innovations happening out there. In a special way, I would like to welcome each and every one of you and also our presenters and panelists. I would like to welcome Christine Steglin, who is the Executive Director for Frontline AIDS, and also to welcome in a special way Anne Aslett, who is the Chief Executive Officer for Elton John AIDS Foundation. Welcome to everyone, and especially as well our panelists, who will be talking and sharing about their experiences and also their innovation. Let me say at this moment that this webinar is being recorded and we'll be able to share the link at the end. But at the same time, we would want to hear from you. So come in the chat box, introduce yourself, tell us your name, the country that you're in, but also the actually presenting. My name is Grace Kwinda, and I'll be moderating this session on behalf of Frontline AIDS. At this moment, let me welcome Christine, who is going to basically give us some welcome remarks and just set the stage for us. So over to you, Christine.
Wonderful. Thank you so much, Grace. Welcome, everybody. I'm very happy to see you all. Thank you for making some time. I know we're all running from one webinar to the other, so we really appreciate for the panelists to make the time and also all of you who are here to participate. I'm very excited to share a little bit of our experiences in the next hour or so. Special welcome to Anne, who is here. And a special thank you to Anne for her personal support, but also the support of the Elton John AIDS Foundation, not only over the last year, but especially last year, which was a difficult year for all of us, to our partnership and enabling us as Frontline AIDS and as partners to really respond to the challenges that COVID-19 brought to all of us, but also, most importantly, to the most marginalized communities who, as we all know, are often also the most impacted by HIV. So welcome, Anne, and we'll speak a little bit later at the end of the session. So as Grace says, today we're going to hear more from innovators, community innovators that have been supported through the Elton John AIDS Foundation, either the Catalytic Fund or through the newly established Accelerator Innovation Program. So all of them will tell you a little bit more about themselves when it's their turn to be speaking at the panel. I just wanted to take one moment before I share my own reflections to acknowledge that sadly one of our panelists is not here today, and that is not because he didn't want to be here, but because of the very difficult situation that his country is in right now, and that's John Mung from Charity Services for Friends in Myanmar. He was due to present on the panel, but he's unable to join us, partly because of the very difficult internet connection at the moment in Myanmar. But obviously, as you have all been seen from the news, it's a situation that is really increasingly becoming volatile and violent. So sadly, he can't be here. Just to say that Charity Services for Friends were one of the 5 organizations that had been selected for a catalytic grant from the Rapid Response Fund. They've been doing really important work ensuring that people in Myanmar have access to HIV treatment, especially since the COVID-19 restrictions or lockdown restriction closed the border between Myanmar and India, which left over 1,000 people living with HIV without access to treatment and services, and Charity Services for Friends were able to work with those people that were really in quite a challenging situation. So we would have loved to hear from him, but sadly that's not possible today. Just to make a side note, as Frontline AIDS, we have had a long partnership in Myanmar. We have a strategic partner there, Mahamate. in Yangon, and we've got many different partners that we have been working with over the years. We're in constant touch with our peers and colleagues there and friends there. But as I said, even though we know that everybody that we are in touch with is safe at the moment, it is a worrying situation. And so I thought it's important that we keep our friends, colleagues, and partners in our hearts and our thoughts as we're having this discussion today. So just a few words about the background for the discussion that we're having. This is, really based on the fact that since the beginning of COVID-19, Frontline AIDS has seen partners, doing amazing things to innovate, to mitigate the impact of COVID-19. Lots of different things, from taking peer-led models into online spaces, carrying out massive community mobilization for COVID-19 and HIV together. So really giving meaning to integration, moving provision away from clinics and into the hands of the most marginalized people more directly and into communities more directly. And the list goes on, and you will hear more of this in the discussion. And often, our partners have been able to maintain the essential provision of life-saving HIV services, but they have at the same time also managed to capitalize on some of the unexpected opportunities that COVID brought to us. And in the beginning, I remember several of you, and I remember with Anne, that we often talked about, can we really talk about opportunities at a time that feels so difficult for all of us? But I think we have all become a little bit more okay with saying COVID has been challenging, but it has also helped us to think differently and work differently. So it has been an opportunity in some ways. There have been massive adjustments between the public and the private institutions, and especially in communities, making their ways of working, changing their ways of working almost overnight, and showing us really that in crisis, governments and communities can work together to quickly introduce changes changes really, and doing things differently that under normal circumstances might have taken months or sometimes years to do. Again, there's plenty of those examples, take-home methadone being one of them, for example, right? That always comes to my mind. So we must leverage the COVID-19 epidemic to introduce important policy and programmatic innovations and adaptations, and to capitalize on the potential of these changes to benefit marginalized communities in the long run, so that we don't think of this just as a response in crisis, but really take that learning into our long-term responses. Across the Frontline AIDS Partnership, we have seen solutions that disrupted conventional ways of service delivery and information provision as a direct response to COVID-19. And sometimes with rather small investments, really, these innovations could be strengthened, scaled up, and expanded to other countries, to other organizations. And I think, in my view, most excitingly, to other development challenges, to other health and development challenges outside of HIV and out of COVID. And so our partnership with the Elton John AIDS Foundation really has enabled us to amplify that work. So just a few thoughts on what have we learned, a few things. One, investments in HIV community-based COVID-19 innovations reach much further than just reaching people living with HIV or people being affected by HIV and AIDS. Two, COVID-19 innovations are built on the HIV infrastructure and can be leveraged to improve the HIV response. It does both, right? It works on the infrastructure that we have all collectively built, but it's also improving it. And then in turn, those improvements are strengthening the broader health system, which is an important point to make over and over as we're having discussions about universal health coverage and so forth. And then lastly, the role of communities responding to a crisis has shown us more clearly than ever that communities have the ability to reach those who would not otherwise be reached through standard government services. And we have known that in the HIV response, but now maybe the world has also seen that. We also know that communities are resilient and that COVID-19 has been one, if not the biggest test of community strength. And COVID-19 has left communities knowing more about what pandemic preparedness means and how to better deal with future shocks. And I think we need to keep on reminding ourselves about that resilience and that community, that pandemic preparedness, because this is not going to be the last time we are going to be in a crisis like that. Now that we're coming through the second and in some places the third wave of COVID-19, or sometimes when I look at some parts of Africa, I actually feel like we're only just being hit by COVID-19, because while we have been struggling with lockdown regulations in many parts of Africa, we haven't actually felt the epidemic yet, but we are now seeing that happening in communities, more and more people being infected and more people dying actually. So while this is happening and while we are moving into a different time of the epidemic, what do we think about? Just 3 thoughts. What are the key strengths or existing building blocks that communities and organizations are using to respond to this protected crisis? And then 2, is the community response to COVID-19 being used to support other health issues, including the vaccine rollout, when and if vaccines are arriving in our communities? And then thirdly and lastly, which of these interventions can be sustained beyond COVID-19? What is the opportunity for domestic financing of these innovations? And can we actually still talk about domestic financing at a time when we know that all our governments are talking about making cuts and having less and less money available because of the economic impact that the pandemic has meant in many of the countries where we are? I leave you with those thoughts. I want to just thank all of you again for joining the event today. I'm really looking forward to an interactive discussion. I know Grace is a master of making it interactive, and really taking full advantage of talking about what we have learned during a difficult year and how we build forward for a stronger HIV health and human rights response, and always with the same vision in mind, right? Ultimately, for all of us, it's about ending AIDS for everyone, everywhere, despite the fact that we're talking about COVID. Thank you and welcome.
Thank you so much, Christine, and thank you so much for those inspiring words. There's so much that we learn from you, and thank you for your leadership, for Frontline, but also the partners that have joined this call. From what you were saying, there were 3 key words that kept on coming to me. We need to learn, we need to innovate, and we need to leverage. And we hope that through the conversation that we're going to have today, we're going to pick some of the innovations and learn how to implement that across our programs. You've also raised critical questions that we need to be thinking about. How do we sustain or scale up the innovations that we're going to be talking about today? At this moment, help me welcome our stellar panel this afternoon. These panelists are representing organizations that received funding from Elton John AIDS Foundation. Some of the organizations have already implemented the interventions, but we do have other organizations that will start implementing the innovations. So at this moment, I would like them to introduce themselves, who they are, but also talk a little bit about the innovation that they're implementing. So I'll start with Olubi, and we'll take it from there.
Okay, my name is Oludikpe Olubi. I work for Improved Sexual Health and Rights Advocacy Initiative. But first of all, I just want to appreciate the Frontline aides for giving us the support to be able to reach out to our community during the COVID period. You know, it's a very sad period, for the life of LGBTQ person, especially the MSM and the trans people, because we cater more for the MSM and the transgender people here in Nigeria, in Lagos, Nigeria. And the grant has been so supportive because we're able to do a lot of programs for our people. Development of comprehensive online outreach and peer support to reconnect to service people who were cut off due to COVID-19 restriction, and the provision of information, commodities and testing, and the redesign COVID-safe physical set of services intended to ensure that future lockdown are much less disruptive to service access. So the project is very, very innovative because we were able to get feedback from a lot of our people, a lot of our, a lot of our beneficiaries, especially those people that are living outside of Lagos, because a lot of LGBTQ people in Nigeria are migrants. They move around a lot. And during the COVID time, there was no access to their treatments. There was a lockdown, there was a lockdown in Nigeria during that time. So before people can move from one state to another, because in Nigeria, we have close to like 36 or 37 states in Nigeria. And during the COVID time, there was no movement, there was a restriction. Before you could move out of Lagos State to Ogun State to Delta State to Oyo State and other states, you need to have a pass from the Ministry of Health. And if you don't have a pass, you cannot travel, you cannot move around. A lot of our people are beneficiaries of our services. And during the COVID time, there was no way they can be able to get their support, their treatments, their ARV treatment. It was so difficult. People were, especially the trans people, their rights were being violated. Their family got to know that they are trans people. They were pushed out of their house. And some of their family knows about that they are taking ART treatment. And in that situation, they sent them out of their house and were able to provide them with a safe house where they can use, where they can stay, so that they can be able to get themselves. So the support from Frontline AIDS, it's very, I just want to thank Frontline AIDS for the support. It's so great. We appreciate. I wish I can be able to bring all my community members to, to say thank you. It was impactful. Thank you so, so much. Thank you very much. Okay.
Thank you, Olubi. It's quite inspiring to hear some of the work that you've been able to do. May I ask Tung to introduce yourself? Let's keep it brief so that we have enough time for conversations.
Sure. Okay. Good morning, everyone. My name is Joel Simpson, and I'm the Managing Director at SASOG Guyana. SASOG Guyana is an almost 18-year-old human rights movement and organization that's dedicated to leading change, educating and serving communities to end discrimination based on sexuality and gender in Guyana and the Caribbean. We have 3 flagship programs through which we achieve this goal. We have our human rights program, our homophobia's education program, and our human services program. In terms of our catalytic grant, the resources provided through Frontline AIDS provided the opportunity for us to conduct a qualitative assessment of how key populations were experiencing HIV services during the pandemic. So we were able to talk to both key populations who are living with HIV and those who are of negative or of unknown status who try to access prevention services. And we were able as well as to also talk to stakeholders from 4 of the most populous regions in Guyana, 4 of the 10 most populous administrative regions, which really covers 75% of the population. Through the assessment, we were also able to document a couple of case studies which show good practices for responding to HIV during the COVID-19 pandemic for key populations. And those included systems that were put in place by the national program, like multi-month dispensing of drugs, similar to what my colleague said before, because of restrictions in movement and so on. What the national program was able to do was to dispense 3-4 months of medication at a time instead of 1 month or 1 month supply as they would usually do, to reduce the frequency for which clients would have to come to the clinics. Then we also developed an advocacy toolkit based on the findings and recommendations of our qualitative assessment. And we use that advocacy toolkit to train key populations themselves, the persons that we interviewed in the study and other members of the community, to be involved in advocacy with us, with health officials and policymakers. And the final component was actually the lobbying of health officials. We were able to meet with the Minister of Health, the program manager of the National AIDS Program Secretariat, the Director of Disease Control, and other high-level health officials in our country to present the recommendations and findings and for them to hear from the populations themselves who were affected. And I'll cap it there. Thank you.
Thank you so much. Can we go to Tang?
Hi, everyone. It's Tung. I am the Executive Director of Lighthouse Social Enterprise, a 15 years LGBTIQ and young key population lead organization working toward a future of better health, equal rights for the whole LGBTIQ community and young key population in Vietnam. I think it's similar to other countries that COVID has changed everything in Vietnam from very beginning of the first outbreak. The Vietnamese government has applied the drastic and tough prevention measures such as like social distancing, travel restrictions or lockdowns. So it's indeed have been effective in the controlling the outbreak. However, it also creates heavier burdens and difficulties for like people who are marginalized, especially those living with and affected by HIV in accessing the needed services and medications. So for example, like the inability to access the essential preventive services, lack of medicines, less income to abilities to afford the basic health services, stigma and discrimination in local health facilities, and lack of awareness on updated regulation from the government on COVID and also on the drugs dispensing, lack of community connections and interactions, etc. So with Frontline Aid Support, we have focused on addressing the above urgent needs of the community with initiatives such as like providing the mobiles and online services. We also connecting the online communities, updating the information on COVID and also HIV, challenge the myth of the community between the COVID and HIV correlation. We also deliver the HIV and COVID prevention commodities, HIV self-test kits to the client home, and also participate in the interprovincial peer support network, and also build capacity in using social media and technology for key population organization to deliver differentiated service to the community during and beyond COVID. So I'm very happy to be here today, and thank you very much for having me in this very interesting webinar.
Thank you. Grace, should I go on next?
Yes,
Excellent.
please go ahead.
Okay. My name is Ashim. I am the Chief Executive of Alliance India. It's India's leading HIV response organization. And we work across the country, which is a large country, as you all know, so everything's at scale. In terms of the innovation, just to say that we initially were shocked and awed by the impact of COVID-19 and the lockdown that followed after that. And we really didn't know where to start and what to do. We were just firefighting all the time. But then we began to realize that there was an opportunity here in the crisis. And I hate to say this because a lot of people were suffering a lot. But then we realized that a lot of people who were not part of the HIV story had become part of the COVID-19 story, which is great for us because we said that now we've got opinion makers on our side, we've got ministers on our side, we've got all kinds of people, actors, celebrities on our side, people who are suffering COVID-19 who will understand better what people living with HIV went through and go through. So we decided to adopt an approach which we call the combined approach. And this is where the Elton John AIDS Foundation, and Frontline AIDS comes in, where I think they were very supportive of the idea, and Frontline AIDS gave us a lot of inputs. And then we took it on as an approach which would be basically an action research proof of concept program, and we would use our lessons learned from the HIV response and use them to address COVID-19. So it's a very clear case of ensuring that the same resources, the same staff that we have across the country will work on both diseases together, starting from prevention to testing to all the way to treatment, and of course vaccination and the social mobilization, because there's a lot of vaccine hesitation. So that's the program that we are implementing at the moment. And we can speak more about the program as well as answer other questions later on. Thank you, Grace.
Thank you so much, Ashim. We look forward to hear more of your work as we go ahead with the conversations. May I ask Dr. Pasquin to introduce yourself, please?
Thank you very much. Good afternoon again. I'm Dr. Pasquin Ogunsoya. I work with Alive Medical Services as the Executive Director. And as I mentioned already before that, AMS is the biggest partner of Frontline AIDS in Uganda, implementing HIV and sexual reproductive health and rights services for the most vulnerable and marginalized population since 2018. And I would like to thank Madam Christine for her leadership and the team at Frontline AIDS. I would also like to thank Elton John AIDS Foundation for the support that has seen the lives of thousands of marginalized populations saved and living better. So Alive Medical Services is a non-profit organization in Kampala. We offer free comprehensive HIV and AIDS services to all, and we focus on vulnerable and marginalized populations, both with in-reach and outreach services. So AMS has been promoting self-care interventions for a while now, and we were one of the 2 pilot clinics in the whole country to run a CDC-funded HIV self-testing services. So during the COVID-19 pandemic, we promoted HIV self-testing to the LGBT community and young people seeking information and advice through virtual platforms because there was a lockdown. So based on the success of this, AMS is now providing virtual and mobile integrated and differentiated self-care interventions with and for vulnerable and marginalized people in the country. So we realized that COVID-19 pandemic has called for a paradigm shift in the delivery of health services with a greater push to the community and less focus on the facility and using a differentiated service delivery model and to meet the needs of the most marginalized population. So during the lockdown, where there was travel restrictions, people kept increasingly accessing information, products, and interventions outside of traditional healthcare facilities. Much of health we know is done at home, and products and information are being increasingly accessed through stores, pharmacies, or in the internet. So self-care interventions, virtual and mobile community services can assist in decentralizing services, pushing services into the community where people can access them safely and anonymously. And we also believe that this can help if there will be pandemics in the future, the impact may be a little reduced. So this means modeling and decentralizing services for vulnerable and key populations with a peer-led approach. It also means self-care for HIV, COVID, sexually transmitted infections, opportunistic infections, treatment, family planning, at home. And we believe that this can become a common practice, and it's something that can be an acceptable model that can be developed for and with key populations. So future airborne pandemics and lockdowns will not disrupt HIV provision so dramatically. So that is the innovation we are implementing right now. Thank you.
Thank you, Dr. Pasquin. Finally, our last panelist, Cosmas.
Thank you, Grace, and hello to everyone. My name is Cosmas Kamba from Pakachere IHDC, Malawi. Pakachere is implementing health programs and social behavior change communication interventions in Malawi. Some of the services that we offer include comprehensive and integrated HIV and SRH services to key populations, age-wide abuse, and other priority population, Let me acknowledge frontliners for the support during this COVID pandemic to implement and scale up digital referral system and SMS platform for a full range of integrated HIV and SRH services to enable female sex workers access integrated basic health services timely and feeding into the national health programs. There has been a lot of positive outcomes that have come as a result of the digital referral system and the SMS platform in efforts to reduce new HIV infections within our target population. So basically, the innovation is about the digital referral system and the SMS platform. Thank you very much.
Thank you so much to all our excellent panelists who are all leaders in their own right in their countries where they are speaking from. I want us to go a little bit deeper and dive into a little bit more of a conversation. And my first question would like to go to Tom. COVID is here. What are the two things that you're doing differently as a result of COVID?
Thank you. Well, like I introducing before, I think two initiatives that we implementing under the Frontline Aid Support. The first is to provide the necessary HIV and COVID preventive commodity box to the client's home who weren't able to travel and access to those commodities. We found that there are many young key population weren't able to access the needed HIV and COVID preventive commodities to keep them safe because they lots of the income, they have no jobs. Why the sexual activity increased due to the free times and ease to finding the partners from the dating apps. So some people also sell sex to have the income as well. So from our peers network and social media channels, we provide online counseling on mental health, HIV and AIDS, harm reductions, and etc. and mail the preventive box to the client's home with their consent. Our doctor also outlined the remote and online examination to client in need. Besides, we also join an interprovincial peer support network to timely update about the new legislation regulation related to COVID, ARVs, and PrEP dispensing, provide the timely support to the community, and connect with the local community organization to get help and ensure the treatment is not interrupted, especially those trapped in the province or the inability to travel to the registered treatment facility. And we also documented the community issues, the rights violation they face, subjected personal information leak out, stigma and discrimination in healthcare facilities, and reported to the Vietnam Administration of HIV/AIDS Control, Ministry of Health for action. And second initiatives, I think we are going to organize a training course for key population as CORD Vietnam on using social media and technology to continue support community and provide the differentiated service to the community in the similar crisis like COVID. Due to the influence of the COVID, social network and information technology are gradually become the popular and alternatives for the face-to-face activities. So it is also predicted to be a new trend for many sectors in the future, including, both healthcare and HIV response over the world. Community organization in the big city has also started to implement some initiative applying social media platform and virtual platform, to mobilize community and deliver services to the community. But some community organization in the remote area or rural area, they have not much experience and capacity to implement those kind of activities. So with our realistic experience, we provide the practical empowering the knowledge to the local community organization across Vietnam on the use of social network in information technologies, and also its feature to apply in their community activities and service delivery to the community. And from there, it motivates them to, act and brainstorm initiatives to provide differentiated service to the community in the future, and also actively participate in the contributing to the national HIV and COVID response in Vietnam. So that is very brief about two of our initiatives under the grant.
Thank you so much, Tang. Just a reminder to our participants, please comment in the chat box. If you have a question, you have a comment, as our panelists are speaking, please go ahead and proceed to comment. We'll be able to tend to that later. And on the same question, I would like Joe to also respond so that we hear another perspective from another country in terms of what is it that you're doing differently in the context of COVID. Joe, over to you.
Thank you. I think one of the things that the pandemic has forced us to look at differently, with all the restrictions on physical distancing and not gathering unless it's absolutely necessary, is how we can use information and communication technology more optimally, more effectively to provide services. And we recognized very early on in the pandemic that we could still sustain a lot of our critical socioeconomic services by using ICT without in any way discontinuing or limiting the service. So we were able to move our counseling and psychosocial services online using virtual platforms like WhatsApp, Zoom, Skype, and so on. We were also able to move our human rights documentation services in terms of taking reports of human rights violations, which did not stop during COVID-19, but took different forms. We saw cyberbullying becoming a lot more prevalent, and we saw an increase in family violence in the context of, especially affecting LGBTQ youth, who are now forced to stay at home with homophobic family members and relatives. And we were still able to do intake for our human rights documentation program virtually, whereas in the past we'd have people come to our office physically to make a report. We were able to take reports via the same communication technologies using WhatsApp video calls. Persons could send photographs of documents and injuries and things like that and so on, so that we were still able to provide and sustain some of these services in this way. And I think what we've learned from all of this is in some ways, we can reduce costs for both us as the provider and the client by utilizing some of these virtual mechanisms a lot more effectively, a lot more optimally. It does reduce costs on both sides. And while you can't do everything that you need to do in terms of provision of services virtually, there's a lot that can be done and a lot that can be done optimally with the use of ICTs. And that's one of the things that we are doing differently.
Thank you so much, Joel, for that response. It seems like communities are innovating and adapting to the situation that we have. Olubi, I think we'd love to hear from you from Nigeria. What are some of the existing strengths that you're drawing upon your work from the HIV space to respond to COVID? I think as Christine was speaking earlier, she talked about there are systems and structures in the HIV program that we've learned from and we are bringing along as we are responding to COVID-19. What has been your situation in Nigeria? You're on mute.
Yeah, I'm sorry for that. Okay, so what are the three main existing strengths we've drawn upon from our work on HIV to now respond to COVID and to reach the community? Well, for us at ISRI, from our findings, we discovered that economic factors are also other matters that affect the community that we serve. A lot of our community are not really economically, okay. So the economic factors are also other matters that affect the community we serve. And community members have had to engage in a risky and unhealthy behavior to earn their daily meal. Sex for pay, sex for shelter are a common practice among young MSM in the state we visited. So there are some states that we visited in Nigeria, like Oyo, like Kwara, Ondo, and some other places that we find a large number of LGBTQ persons. So therefore, you have learned that providing HIV prevention and treatments would not be effective enough to solve the HIV rise in the community, in the MSM community. An intervention that also looked into empowering community members through vocational training will go a long way to reduce such risky behaviors that make LGBTQ people more socioeconomic vulnerable. And also unfriendly legislation. The project was to curtail the spread of HIV within the LGBTQ community, and we discovered that unfriendly legislation has been a barrier. For instance, we discovered that in some states, community facilitators, that is, people that the gatekeeper, were often harassed by state actors in their dissemination of their duties, which include testing and enrolling and providing a prevention commodity. Also, getting people to show up at outreach program was a difficult task because community were scared of state actors getting involved in the program. However, we're able to work around this through the use of key opinion leader and gatekeeper within the community. And also the unfriendly healthcare worker. In our findings, we discovered that some healthcare workers are in need of more sensitization on HIV and AIDS program. We discovered that community members have often decided not to seek medical help from public health centers because of the unfriendly attitude of healthcare workers and are usually unable to afford private healthcare facility. Therefore, many go untested and not aware of their HIV status. We recommend an intervention for public and private healthcare work on SOGI-related issues. So for us at Israel, we're able to support people during that time, during the COVID time, to be able to address some of these issues that the community members are facing, and also being able to develop a comprehensive online outreaches and peer support tools to connect to our service people who were cut off due to COVID restriction, provision of information, commodities and testing, and redesign of COVID-free physical sets of services, instead of ensuring that future lockdown are much less disruptive to service access. Thank you.
Thank you so much, Albi, for sharing some of the work, especially talking about the role of working with community leaders, but also just working with attitudes of healthcare workers, which is both critical in the HIV field, but also now with the COVID pandemic as we work and respond in that space. I would like to go to India now, to Ashim. Are there any existing structures, referring to the same question that I asked Olubi? Do you have any existing structures or system you have that were developed in the HIV programming, but you're now using to respond to COVID-19? If yes, do you feel any of them can be sustained or scaled up beyond COVID-19? What's your reflection?
I think one of the most interesting and powerful systems or structures that the HIV movement has created for itself is that it has placed communities at the heart of the response. And in India particularly, I cannot speak for other countries, but the programs that Alliance India implements are peer-led, they are community-led and not community-based. There's a distinction. And I think this is where the strength lies, the real strength lies, because we were amazed, inspired, absolutely inspired and taken aback by the strength of communities during the immediate response to the lockdown situation, the hunger crisis, the migration crisis, but beyond that, when people had COVID or had to be hospitalized, or sometimes when family members died because of COVID, there was a tremendous connect within the community. So that, I think, is the biggest strength. And I just want to refer to drug users in particular, people who use drugs. We realized that whilst harm reduction services, of course, had gone completely awry, but it was people who use drugs who sort of stood together as a very strong community in India. Partly, you could say, yes, Alliance India contributed to the process by bringing collectivization and so forth, creating state-level forums and India-level forum, etc. But beyond that, I think they were the most marginalized, and that led them to collectivizing better, becoming stronger together. And right to the point where we were able to prevent, through Alliance's efforts, I can say, where there were other efforts as well, close to 15,000 deaths due to overdose, because the conventional drugs that people who use drugs use were not available through regular channels. So there was a lot of overdose, and there was a lot of the problems in drug use, which meant that communities sort of created these structures which stood together. Now, this is something that is going to sustain, Grace. It's not something that will go away, because the generosity index, as we call it, has increased manyfold in this country, and it's communities standing for each other, whether it be sex workers or people who use drugs.
Thank you so much, Hashim. It's good to talk about how do we move and sustain the innovations. So it's quite good and refreshing to hear your reflection on how that will be sustained beyond COVID-19. But we've talked quite a lot in terms of some of the good aspects of the innovations, but I would like to ask Dr. Pasquin if they've experienced any challenges with the new way of working in the context of COVID-19 and the innovations that we're talking about. What are some of the challenges that you're experiencing with this new way of doing things?
Thank you very much, Grace. I'll talk about the challenges we are facing as Allied Medical Services. Our innovation has been self-care interventions, virtual and mobile community services for vulnerable and marginalized populations. So the first challenge we met was that some of the staff or health workers were not experiencing virtual or self-care interventions, but we have also mitigated that by training of the health workers. Then, of course, the second challenge would be exposure to COVID-19. That's why we've been advocating for the health workers to be vaccinated, but also we train the health workers and monitor regular screening as they go out to do the mobile clinics, the virtual services, so that we have put measures in place for personal protection from the infection and also control guidelines. Then the other challenge is because it's a virtual services, self-care interventions, there's a lot of virtual communication. So sometimes the marginalized populations themselves will not maybe have internet access or airtime for credit. So that's still a big challenge. And then of course, the other challenge is that when you want to give multi-month refill for the clients, maybe we are not able to give so many months. So that has been a challenge. Thank you.
Thank you so much, Dr. Pasquin. There's a lot of conversation going on in the chat box. I would just like to encourage you to keep on bringing the comments on. We'll have time to respond and also just comment a little bit on some of the input that is coming in. At this moment, I want us to talk to Ashim, if you can come back. Do you see any change in the role of communities in terms of the way we are responding to HIV during this pandemic? Do you see any changes? Is it good? Is it bad? Is it the same? What's your reflection, Lily? Do you think the way we're working now will remain like this? Or I just want your reflection on this.
Yeah, I'm blinded by love, so I'm not going to say anything bad. Everything about people we work with, communities, is great in terms of, there has been no selfish sort of, insulating or, effort by communities to only seek for themselves. So there's been a lot of spread of the goodness. But I just want to refer to two aspects, whilst there are many, two aspects that have been very, very powerful in terms of the change. One is the focus on gender. And there, I think, and especially women, I think there we were lacking. And as the pandemic progressed and the lockdown progressed and the impact was felt disproportionately on women, I found that the community as a whole, but women also amongst themselves, were willing to look at certain issues that they hadn't looked at earlier on. Like, for instance, just something as simple as sanitary pads, right? Sanitary napkins. I don't know how you use, what expression you use. But anyways, just to say that, menstrual hygiene became an issue, and it became an important issue when it came to distribution of food products. That was not something that had been thought of before. Intimate partner violence became a very important issue. And we started thinking about female sex partners of drug users, which also meant that we were looking very differently at communities as we were done before. So gender was one aspect of. The other aspect that was very interesting was social protection. And hitherto, communities were not entirely focused on social protection, but for the first time, and I mentioned this to Chrissy, I remember when I joined Alliance about a year ago, that one of the biggest impacts of the COVID-19 pandemic has been a huge rise in activism, and bringing together of the various political forces within the movement that did not see eye to eye earlier on. They came together and they sought a $10 million support from the Global Fund that was approved for social protection. So key populations asking for $10 million from the Global Fund, getting it approved, and now we're just going to start from the 1st of April to just disperse it. I think is one of those very fascinating changes that the community now realizes that it's not just about ART and health services and HCB and what have you. It is also about social protection. So gender, social protection, two big changes.
Very, very interesting. I think it's true to say COVID-19 has really brought a lot of dimension in the way we look at HIV programming. You talked about intimate partner violence. A lot of countries have seen a rise in IPV and intimate partner violence during COVID. In Nigeria, I would want to hear in terms of, do communities have more voices on the table at this moment? Dr. Pasquin, do we have more community voices in terms of influencing how programming is done for HIV during this pandemic than it were before? Or what's the situation like in Nigeria? Just beyond looking at the changes, but how are community voices at the moment in your country?
Thank you very much, Grace. I'm actually working in Uganda, though I'm a Nigerian. So responding to that, if we see any change in the role of communities in responding to HIV during this pandemic, I see the bad one. I also see the good one. So the bad one actually is at a global level, the global community, because of the way COVID-19 pandemic came, there's a way attention was drifted away from HIV services. And this is a significant threat for people living with HIV globally. So already COVID-19 has caused serious damages to some of the gains that have been made that actually disproportionately affect vulnerable and marginalized populations. So from the community level, there is also the part that is not so good. Like my colleague Ashim has mentioned, there has been a lot of gender-based violence that has increased, partly because of the effect of COVID-19. There's economic challenges, people have lost their jobs, and people have lost their businesses. So people are confined in one place. So mental health issues have gone up as well. So this has caused violence, intimate partner violence. There has been in Uganda, actually, there's been a lot of teenage pregnancies because the girls have gone back home. There has been no school. So those are some of the challenging situations. But there is also the good aspect of this pandemic, things that my colleagues have said. This is a time when we saw that communities can really stand together and support one another. We also saw a great response in the community where people stood for each other. People were generous towards each other. People living with HIV would walk to pick medicine for their friends. So there was that community caring for one another, looking out for one another, pulling resources together. We saw some communities actually were doing cash transfers to help people who are really in need. Food was being donated to help people who are in need. So we saw that community also realized that actually maybe government or the government may not be able to help support them at that time. So community begin to realize that we need to be prepared when there is a pandemic. So there's that self-care, social protection. Community began to really realize that they need to do that. So there was the positive part, there was also the negative part. Thank you.
Thank you so much for that reflection. Chung, recently your work was captured in a recent documentation visit. Can you tell us a little bit more about that process and your work? May I ask, if possible, for us to see some of the, thank you. You can go ahead, Chung.
Yeah, so as you can see on the screen right now, the Lighthouse Clinic still open during the COVID outbreak. And we not just a clinic, we are a community center where community can come over and talk to our counselor and reading books and also meeting other in there. And also receive the friendly and quality services, not only HIV, but also mental health, anti-HIV, and so harm reduction. So this is the picture we took when one of a young gay man came to our clinic, and after services, he also received the bulk kits. It's not only the condom and lubricant HIV self-test kits, for himself and also for his partners, and also with the face mask and also hand wash. Yeah. Yeah, and yeah. And here, as you can see, more clear about the kiss box. So we have the HIV self-test kit. We also have condom and lubricant that's in one box that we redesigned to make sure that it's more attractive for the community, and they will demand to use the condom and lubricant during sex. And we also provide them the materials like about the EU for you message, and also the PrEP and HIV prevention during COVID, also with the face mask and hand wash. And here, Mung is one gay man who living with HIV and also on treatment, and he served at the Lighthouse Clinic as a counselor. And also Tung, a 17 years old gay man who came for us through our website seeking for the PrEP services. And both of them, and Tung also just become our new peer educator, and both of them are exchanging the experiences and counseling and outreaching skills with each other over the tea near the Lighthouse Clinic. And they also learn from each other on how they can better support for community by using the virtual platform and social media platform. And in order to provide the friendly services to the community, so we have the multiple poster for the community explain about the meaningful of the EU message on how they should keep maintained and adherence on ARV treatment. And you also can see that the small size from the LGBTIQ community is endorsed that Lighthouse Clinic is one of LGBTIQ friendly clinic with a very powerful message, love wins. So everybody, when they come here and they see the sign, they feel like more comfortable, and this is a safe spaces for them. And the last pictures, Ngọc Hà is one young transgender woman who lost her jobs during the COVID outbreak, and she returned to her hometown in Haiphong. Is more than 100 kilometers far from Hanoi, and received our kit box and also mental health counseling during the COVID outbreak. And her main jobs and main income come from the drag queen and also makeup. And these pictures show her careers during the COVID outbreak. Yeah, those kinds of pictures is, simply explain about our innovation during the COVID to support community. Thank you.
I wish I could actually clap hands after looking at the beautiful pictures. People actually say pictures say 1,000 words. That was really a lovely way of showing us the work that you've done. Thank you to your team for making sure that marginalized populations are being saved in this time. And I think a special thank you to even Frontline AIDS, but also Elton John AIDS Foundation for making this work possible. It's exciting. I think I'm excited to see all this work that is going on, but I think it's also it would be important for us to look at impact. So I would want to ask, if possible, Joel, if you could respond to this question. How has your innovation, the innovation that you implemented, how has it impacted on the lives of the most marginalized population in your community? Joel?
Well, yes, thank you. Well, I think while our innovation, I think, went hand in hand with some of the humanitarian relief work that we're doing, under our innovation project with Frontline, we focused on advocating to fix some of the structural issues. And I think that was very important. A lot of our other work provided humanitarian relief, food packages, hampers of cleaning supplies, personal and protective equipment, and so on for populations that needed them. But it was clear that we needed to fix some of the structural issues to be sustainable. And I think the opportunity to assess what was happening and to have actual evidence and have actual data, and to be able to present that to the Minister of Health, and have him here not just from persons working at NGOs, but having him hear from some of the populations themselves who are going through these experiences at the treatment sites, at the health clinics in the country. And I think that had the most impact, and that was what was really most important for us in involving the communities themselves in the advocacy. And that's why we made the extra effort to not only just do the research and have a pretty glossy report, but to break it down, to be able to do an advocacy tool, to break it down, train the community to advocate on the findings and the recommendations. So some of these changes could be sustained. And I think some of the things that will benefit the community in the long run are the agreements that the government will try as far as possible to do multi-month dispensation of drugs. given some supply chain challenges. One of the things that we've experienced, though, that has stymied that is stockouts and shortage of drugs during the pandemic. But as far as possible, in principle and as a policy, they agreed with those recommendations about multi-month dispensation of drugs. Another important thing that we heard from the community is that they were very unclear during the pandemic if they could access services in the way that they did prior to the pandemic, if they would be allowed to see the doctor and ask questions and so on. And it was clear that there was a communication gap between the providers and the clients. And the revelations in the assessment prompted the Minister of Health to issue a directive to the program manager of our National AIDS Program Secretariat to say that he should write to all of the doctors all the providers actually working within the national program, clearly articulating so that they understand that the level of service that people were experiencing prior to the pandemic is what they could expect during the pandemic. Interaction times with doctors and providers should not be shorter. People shouldn't feel that they can get tests and so on if they want to be tested. All the services, all the health services needed to be available with the precautions put in place for the COVID-19 pandemic, wearing PPE, sanitizing, and so forth. So I think those have been some of the sustainable benefits that will live on beyond the intervention itself.
Thank you so much, Joel. Ashim, have you been approached by any other partner in terms of the work that you're doing, whether government, private sector, or even funders on your work during this pandemic?
Yes, actually, yes. That's something that was a little surprising. We didn't ask for it. We received it. We became a partner of choice, which was probably because we ensured that we put ourselves into the firing line, and that we did not shy away from the problems that, unfortunately, of course, our government was a little more relaxed than governments of, say, the United Kingdom. So we were able to move around and show that we were on the ground. And as a result of that, yes, corporates did come to us and say that, could we help in distributing food rations or condoms or things such like. And then, of course, beyond that, it was Global Fund when it came to PPE kits. So they wanted us to deliver PPE kits to nearly 40,000 people who are working on the front line across the country. And we did that, or we are in the process of doing that. And in addition to that, of course, I mentioned the 10 million grant for key populations. That also came from the Global Fund, but partly through Alliance. So I would say that there has been a lot of traction in terms of receiving funds. But this is, sometimes people say that, you're doing this pro bono. What is in it for the organization? And I always say that this is why we were established. This is not about, we're not an industrial organization. This is not industry. We're not doing anything pro bono. We are civil society. It's our job. It's our duty. It's why we were established. It's the reason why we exist. And so, yeah, that's what we've been doing so far.
I love the statement that you mentioned. You said we became a partner of choice. I think the more community-led organization can speak like that, I think we'll be assured of sustainable solutions, because we are on the ground, we are in the community, we understand the situation, and we have better way of defining solutions to the communities that we work with. Joel, what about you? Did you have any opportunities and partners coming along?
Definitely, and I think the main one that I will mention is the pandemic created an opportunity to work with the private sector in a different way. And the first partner that was responsive to the needs of our communities in our country were private sector organizations who we reached out to before there were any funds available for humanitarian assistance to provide hampers of cleaning supplies to our communities. And we reached out to those local companies who were either making or importing cleaning supplies, PPE, and so on, very early on March 11, 2020, Guyana confirmed its first case. And by the end of March, we were reaching out to private sector and realized that these items would be needed for people to keep safe, and that because our communities are already at socio-economic disadvantages, people would find it hard to find extra resources to buy bleach and gloves and masks and cleaning supplies and so on. And the local private sector companies were very responsive. So that was an interesting new partnership that emerged almost organically due to the pandemic.
Thank you so much for that. You've raised another critical point that we often talk about, private and public partnerships. And I think as community-led organization, we need to see how we work with private institutions to make our work go a longer way than it is doing now. And I would want to ask Cosmas, he hasn't spoken so far. So I would like to ask him to come in and just respond to, if you were given $1 million, no restrictions, and unlimited resources, what would you like to see happen or sustained after COVID-19? This is the $1 million question.
Yes, thank you very much, Grace, for that question. So with the COVID pandemic, we have seen an increase in demand and the utilization of the mHealth in developing countries. And as I said in my introduction, that at Pakachere, we introduced the digital referral system and an SMS platform that we are using to reach out to our target population with healthy messages, demand creation, awareness of services that we are offering at the drop-in centers and at outreach clinics, sending appointment reminders for ART clinics, and more importantly, as a feedback mechanism for quality of services that we are offering. So if I had $1 million, I would sustain and scale up this digital referral system and the SMS platform and ensure that we have a wide reach and with comprehensive packages. And these comprehensive packages would be delivered at all levels, including facility and at community. So at community level, our peer cadres, peer educators, who mobilizes female sex workers at hotspots to come and access essential health services, and including peer navigators who support HIV positive cohort so that they adhere to treatment and achieve viral suppression, would be mentored and supported to be able to utilize and deliver some packages to their peers using the same SMS platform and the DRS. And this would create an interactive space for these peer leaders and female sex workers that they support. And beyond that, I would also extend the platform, create an ad hoc platform that would reach to men who have sex with men and other priority populations at substantial risk of HIV acquisition, such as the adolescent girls and young women. Thank you very much.
Thank you so much, Cosmas. I'm still shopping, so I'll ask Dr. Pasquin to also reflect through what she would like to see happen or sustained after COVID, if she had $1 million.
If I had $1 million, thank you, Grace. If I had $1 million, one of the first things I would do is I will ensure that the resources, I would ensure that I will use the resources to advocate for human rights and ensure that everyone has the right to access the HIV information and the services they need for a healthy life. Then, because resources for HIV has reduced and yet AIDS is not over yet, I would look for a strategic partner involved in social entrepreneurship to be able to invest and multiply this money for sustainability of the comprehensive services for marginalized populations, and also be able to see the end of HIV. I would also train vulnerable and marginalized populations in income generation skills so that they can equip themselves, protect themselves, and also sustain themselves. I would also train more health workers and community leaders and gatekeepers in stigma-free, non-discriminatory, and friendly services for marginalized populations so that people are treated with love and dignity because they are human. Then I would invest in advocacy for sexual reproductive health and rights for all. I would also invest in letting the world, especially the global decision makers and governments, to know that AIDS is not over yet, so they should increase funds to end AIDS. Then I would advocate for COVID-19 vaccines to be equitably distributed, including in Africa. Thank you. Thank you, Grace.
Thank you so much for that. Thank you so much for that. Before I go to some of the comments or the questions that might have come in, there was a question that we received from the chat box for Ashim, and I think you touched on something that was quite critical. Can you say something about how and why the collectivization of drug users will be sustained after this immediate crisis? I think that was an important aspect that you touched on.
Yeah, I think the collectivization of drug users is, well, it's a first. Drug users have tended to be in very small groups, never organized, a criminalized population, of course, and have tended to be invisible and therefore extremely marginalized. All of a sudden, and especially during the peak of the pandemic, and we are facing the second wave now, the drug users got together and there was a lot of buy-in of their issues by government. They realized that they didn't have to feel scared all the time of police or law enforcement. They could actually bring their issues to the fore because they had organizations like us behind them, but in addition, they had organizations like the National AIDS Control Organization that was behind them. So what I'm basically saying is that they found a voice, and then because they found the voice, and it's a very strong and aggressive voice sometimes, which requires a little bit of tact to handle, but nevertheless, I'm very pleased that this collectivization is there and it's going to sustain.
Thank you so much for that. I wish we could go on and on just having this conversation. And I think we need more platforms like this where we learn from each other in terms of innovation, but also the work that we're actually doing. At this moment, I think there are no questions that were not responded to in the chat box. So let me say thank you so much to our wonderful panelists. It's really been amazing hearing on the work that you're doing, the innovations that you've implemented. Congratulations for all that work. We look forward to hearing more from Alliance India and AMC in terms of the work that they're about to do at the moment. So we hope we'll see more of that work as we move forward. Through the conversation that we've had, there's a lot that has been discussed. We've heard voices from the field and from the people directly on the ground implementing the projects. We've heard from Uganda, Nigeria, Vietnam, India, Malawi, among others. All that we are seeing is the law of communities in responding to COVID-19. We do hope that this responsibility and this role will continue to expand and will continue to innovate as communities. As we said earlier, communities are central to defining solutions to pandemics like COVID-19. We've also heard some of the communities that are coming along for communities and how we've innovated and responded with those innovations. We've reflected on what changes we think can be scaled up and also sustained beyond COVID-19. So thank you so much once again to each and every one of you. And I think at this moment, I would like to give space and time to Anne Aslett, As I initially indicated, she is the CEO of Elton John AIDS Foundation. So let me give her space to just reflect through the conversations that we've had. Over to you, Anne.
Thank you, Grace. Well, the first reflection is this: it's just so extraordinary to hear all of your stories and what you've managed to do over the past year, which has paralyzed the world in so many ways. You've really been incredible, and I'm deeply proud on behalf of the foundation that we've been able to work with Frontline to help support you do this work. I think two things come across very strongly to me from all of what you've said, is how communities have shown compassion, flexibility, and a realism about the problem that they're confronted with in a way that I think in many ways governments didn't. When this pandemic first hit, most governments around the world were paralyzed. They didn't know what to do, and they didn't know how to respond. And the extraordinary thing is that what you've described from the organizations that you work for and the communities you work with, communities did. Now, arguably, they have no choice, right? Governments can fail to do what they should do and can be held to account or not. But as communities, you have no choice but to engage with the reality that's around you. And that really comes across in everything that you've said. And I think it's always been true of the HIV response. You know, we had a show that was aired on television in the UK just last month, which was about the beginnings of the HIV epidemic in the UK, when no one would be treated in hospital, people were utterly ostracized, no one spoke about HIV, it wasn't in any of the media, and LGBT communities just had to find solutions to support one another. I'm so struck by also the compassion and this, I think, various people talked about the selflessness, the kindness. Ashim, I think you said about the selflessness of communities. And it's in such stark contrast to the sort of nationalism and protectionism that you see from so many governments who won't share patents, won't share vaccines. You know, communities show that kindness. They understand that the strength is in what we share. The other thing that really struck me is the extent to which you've all engaged and your communities have engaged with the realities of people's lives. You know, a lot of the rules and regulations and policies that have come in as a result of COVID have been incredibly rigid and blanket. They don't recognize the realities of, I think Joel was talking about, you know, people having to go across state lines, about people needing to access treatment, people needing to work, that they can't just do nothing and stay at home. They need to work to live. And so the communities you're talking about and the way they've responded have really been able to do that. And then the big thing, and it's a measure of actually how inadequate governments are in so many ways in the world we live in now, and how interesting it is to work with the private sector, is that in every single instance, you've all talked about engaging with technology. You've all talked about engaging with the way that we live now, with the fact that you can take things online, that you can provide services online, that you can create social connection on social media if you can't create it in person. And that's powerful. That's a kind of democratization of what we need to do and what we need to share with governments to make them change their policies. When you can share data and information from not just one or two people, but large numbers of people about what they need, what they're missing, how they're managing or not managing, you really can change that. And I think you've also shown that these things don't work in straight lines, that it isn't rigid. You can't deal with HIV one way and COVID separately. If you're imaginative and innovative, you can do both of those things. And you can also look at domestic violence, and you can also look at a range of other things that people live with. And you've done that in so many of your programs, and looked at differentiated ways of doing that in a much more innovative and responsive and flexible way than the big healthcare infrastructures that take much longer to respond to any of these needs. So I'm overwhelmed by just how flexible and responsive you've been. The fact that Christine said in her opening remarks, you know, it feels bad to talk about wins from a pandemic like this, when so many awful things have happened and people continue to get sick and die, and God knows we're not out of it yet. But the things about rediscovering the enormous compassion and flexibility and realism of communities, the opportunity that digital infrastructure represents and how we use it, and the fact that we see people as people, not as a series of different health issues that need to be dealt with, and we can respond in differentiated ways to that, is enormous. And if we can harness the data and the learning from that, and it sounds like in so many ways you are doing that, that's when you get to speak to power, if you like, about IT and bandwidth and better capability for communities to access information and services online. About supply chain, you can really make the case about where supply chains are failing. Training, the need for training community health workers and sensitizing people so they have the right attitude and they're not turning people away and ostracizing and stigmatizing them. And information. And then obviously the biggest thing is policy, going back to lumbering governments who are still trying to figure out what their best response is going to be, and saying, we know what this response is. We have the direct personal experience of that through our beneficiaries. And we also have data which backs that up. And there's never been a time, it seems to me, where governments have been so badly caught out by their responses or failures to respond, either because they've been too simplistic and draconian, or because they've been too slow to figure out the role of the corporate sector, the role of communities. And you occupy this fabulous space where you can share that, both with the corporate sector, but more importantly with government, to change policies now that can make all of these responses much more bomb-proof, if you like, in the future. So I'm deeply grateful. I'm sure everyone on this webinar is, for you having shared your experiences of what you've achieved and what you've done. And I would say the more we can document and learn, I think in the beginning, Grace talked about learn, innovate, and leverage. If you can document what you learn from all of these innovations, we can use it, and organizations like Frontline AIDS and the Elton John AIDS Foundation can use it to create bigger leverage with those institutions like the Global Fund to make change. So thank you so much for sharing.
Thank you so much, Anne, and thank you so much for the support as well to get this work done. I just want to call out to some of the resources that were mentioned in the chat box. I think we had part emergency response that made provided a link to some of the work that they're doing. We had Boost made some of the reference in terms of the work they're doing with peer educators. We have SSDI. So basically to say we'll share this the link to this recording, and you should be able to find those resources. At this moment, let me thank Anne again and Christian for the leadership to bring us to this space. Thank you so much for your leadership, for guiding the process, basically, but also for helping and ensuring that community voices are there as we respond to COVID-19. Let me thank the team from Frontline AIDS that were responsible to organize this webinar. There's a lot of work that was involved, and we're grateful that we're able to pull this off. And also gratitude to the amazing panel. It's been really great to hear from your experiences and your work. And finally, thank you so much to everyone who joined us on this webinar. Have the rest, a good rest of the day. We really are appreciative that you joined us. Thank you and bye.